Thanks for allowing me to speak on this new classification system of adult idiopathic scoliosis. As you'll see, it's modeled after the AIS system that now has been in use for over 2 decades. So as you know, there's a lot of heterogeneity in adult spinal deformity. So what we did basically took a subsection of ASD, and we're going to focus now on ADIS, adult idiopathic scoliosis, for the remainder of this talk. And for classification purposes, we use these criteria. We wanted to make it radiographic because 2D X-rays are still our main means of communication. I want to make it simple, reliable, and to do that, similar to the AIS systems you'll see, we made it modular, which is easier to remember and also easier to add on as needed, and we will need to add on to this system as we'll talk about. Also, it'd be nice if it was familiar, because at the end of the day, AIS does evolve into ADIS when it's untreated. So again, younger AIS patients, I know I treat both kids and adults, so I often will see younger AIS patients who had either smaller curves or curves that were kind of borderline for fusion. I follow them up over time, and often, not surprisingly, they progress and will then require surgery as an adult. So it's logical that we somehow connect these systems, because these are really the same curve patterns, just with often curve progression and degeneration that occurs over time. So we're going to leverage this AIS publication and system that's now been, again, in use for over 20 years now. So probably been familiar with the 3 components: the curve type, the lumbar spine modifier, and the sagittal thoracic modifier for the complete curve classification. As you know, this system is based on the AIS patient really having 3 structural regions of the spine: the proximal thoracic, main thoracic, and thoracolumbar and lumbar. And the big difference in the adult is that we have to pay attention to the lumbosacral fractional curves. You know, that often gets problematic with arthritis, stenosis, rigidity, and that can hugely impact our operative treatment. So we're going to now propose, and we are using a triad system for ADIS classification. And here's the 3 components: similar 1, 2, 6 curve types, because again, these curves are the same as we see in adolescents. They're just now older and often stiffer and more arthritic. A lumbosacral modifier is the second component, is going to be non-structural, structural, based on a supine API image. And because alignment is so critical in all patients, but especially the adult patient, we're going to have a global alignment modifier, which you'll see, with 4 components. So the 6 curve types of the ADIS system are the exact same 6 curve types as the AIS system. The main difference here is that the structural criteria will be based on a single supine AP image, whereas if the minor residual curve is greater than or equal to 35 degrees, that's going to be a structural minor curve. So we're not using side bender curves like we did in the AIS system. We really are strongly promote the use of a single AP image for many reasons as a structural criteria assessment radiograph. We will use the same thoracolumbar junctional kyphosis criteria for structurality, but in the coronal plane, we're going to use the supine image. So the treatment direction is exactly what we had for the AIS patient, that we're going to treat, infuse the structural major curves and the structural minor curves, and not treat the non-structural minor curves ideally. And obviously, in adults, we can treat these all posteriorly if you so choose. The second component is this lumbosacral modifier. And again, this is going to be based, again, on a single supine image. On the left is a supine image with a residual L4 to sacrum 8-degree curve. And on the left is, on the right is a residual lumbosacral curve from L4 to sacrum of 24 degrees. Again, if the lumbosacral fractional curve is less than 20 degrees on supine image, it's non-structural. Greater than or equal to 20 degrees is structural. So the implication is logically that on the left, for a non-structural lumbosacral modifier curve, we try and avoid fusing the lumbosacral region. And for a structural lumbosacral curve, we most often have to include that structural lumbosacral region in the instrumentation and infusion. Obviously, nothing's ideal or perfect, but again, these are just general recommendations. The third component of the system, and again, it's a global alignment modifier. Here we have 4 components: aligned, which is when the sagittal and coronal plane are less than 4 centimeters of C7 malalignment. Sagittal malalignment is a plus 4 centimeter greater C7 SVA. Coronal malalignment is greater than or equal to 4 centimeters CBA, either a positive to the right or negative to the left, and a combined alignment modifiers when you have both sagittal and coronal malalignment. So the new system, again, is similar to AIS. There's 3 components. Includes the curve type, similar to the AI system, but the 2 different modifiers are lumbosacral modifier, the non-structural, structural, and this global alignment modifier, again, aligned, sagittally malaligned, coronally malaligned, or combined malalignment. To make the complete curve classification as an example, you can have a 5S/sagittal malaligned as an example. So in the system before publication, we did inter and intra-rater reliability from both the residents, fellows, and attendings. We had excellent inter-rater reliability as well as intra-rater reliability of these components. Again, these are pre-measured x-rays, so kind of the best case scenario. But again, with a little bit of practice, these are the system's pretty easy to learn and understand, obviously. I want to thank James Lynn, who spearheaded this publication in spine deformity in September 2020. He's now in practice in Mount Sinai, was one of our past fellows with us at Columbia. So again, my approach to ADIS, as you're probably all aware, is posterior only, pedicle screw fixation, multi-rod constructs, as you'll see, osteotomies for release, T-lifts at the bottom for these structural lumbosacral curves. Again, instrument-infused major curves and all minor structural curves. And again, ADIS treatment is similar to all ASD operative treatment. It's very individualized, and I'll highlight that in a couple of the cases. Let's go through some cases to highlight how we use this system to both classify and treat ADIS. So here's a young adult who has a 60-degree thoracic, 80-degree lumbar, 18-degree lumbosacral curve on standing images. She has a thoracolumbar rotatory kyphosis of 46 degrees on her sagittal plane. Her supine AP image in the middle shows a residual supine thoracic curve of 57 degrees, which is, again, meets our structural criteria. Regardless of that, the thoracolumbar junctional kyphosis of plus 46 degrees meets our junctional criteria. So either way, this is truly a double major curve pattern, with the major curve being in the lumbar curve. So it's type 6 curve type. Again, the lumbosacral curve is 12 degrees, L4 to sacrum count measurement. So that's a non-structural lumbosacral curve, and it's aligned in the coronal and sagittal plane as far as C7 plumb lines. So the treatment for this is to fuse both curves. Here we do a T4 to L4 instrumentation fusion with posterior osteotomies of the thoracolumbar junction for both correction of the coronal and sagittal plane and the rotational control as well of this patient. So here's a curve that we're going to look at, an typical adult lumbar idiopathic scoliosis curve. Here we see the supine image. You see the major curve is 47 degrees. So it doesn't really matter what that supines to, because that's the major curve. That's going to be considered structural. The thoracic curve is 22 degrees above. That's non-structural. And the lumbosacral curve from L4 to sacrum is only 14 degrees, which is also non-structural. So the classification is 5 non-structural lines. So the recommendation is just to treat the thoracolumbar curve, to leave the lumbosacral curve alone, and obviously leave the thoracic curve alone. Can we do an isolated thoracolumbar instrumentation fusion here? Well, again, in adults, we have to go beyond, unfortunately, the radiographs. Here in this patient's MRI, you see the stenosis at L3-4 and L4-5, and the touch at L5S1 even. So again, we're going to have to treat this lumbosacral curve for degenerative and stenosis reasons. So we kind of go against the classification system. So here we do a T10 to sacrum instrumentation fusion with T-lifts at the bottom after decompressions. So again, just highlighting that the system isn't perfect. For adults, obviously, we have to look at MRIs, and sometimes, especially the lumbosacral region, that's going to change our treatment based on the classification, even if things are considered non-structural. Here's a typical patient with a little larger curve, an older adult here, a 69-year-old. 43-degree thoracic, 89-degree major thoracolumbar, 39-degree lumbosacral curve on standing images. See this coronal axis is -2 centimeters to the left. The sagittal plane, there's a large thoracic and thoracolumbar kyphosis with a positive C7 SVA of 6 centimeters in the sagittal plane. Supine image, not surprisingly, shows structural thoracic and lumbosacral curves. So the classification system is type 6, structural lumbosacral, and sagittal malalignment for the sagittal malalignment in the sagittal plane. So again, the recommendation for this is to treat both curves, obviously all the way to the sacrum and pelvis. So here we do this with a long posterior construct. See inner bodies at the bottom of the curve to realign the lumbosacral fractional curve. Also take away some of the lower thoracic and thoracolumbar kyphosis. And here she is at 1 year post-op with good overall radiographic alignment. This patient, again, older adult with this curve patterns, who also has malalignment in the coronal and sagittal planes. You see 4.2 centimeters in her coronal malalignment and over 10 centimeters, 14 centimeters in the sagittal plane malalignment. The supine image shows structural proximal thoracic, main thoracic, and lumbosacral fractional curves. So the classification here is type 4, so triple major, structural, lumbosacral structural region, and combined coronal and sagittal malalignment. So obviously this is going to require a long construct with not only regional curve correction, but global realignment, especially in the sagittal plane. So here's her reconstruction, T3 to sacrum and ilium. It's very nice restoration of more normal coronal and sagittal alignment here, and did well from this reconstruction. Here's her total body films. You see even the improvement in the lower extremity compensation following this reconstruction. Here's a bit of an unfamiliar, unusual case, but something we see in the ADIS population, a patient who has more of a coronal malalignment and sagittal malalignment. So his main complaint actually is leaning to the left. You see he's off nearly 8 centimeters in the coronal plane in his alignment. The sagittal alignment is quite good though, overall, in his regional and global alignment. His supine image shows a structural thoracic curve, and not surprisingly, a structural lumbosacral curve here at 27 degrees. So the complete classification here is a type 6S, structural coronal malalignment. Again, another unusual thing here is you see the fused joints at the apex across his concavity. So the question is, how aggressive do we get with this patient? Does he need a 3-column osteotomy? Fortunately, he's not very healthy. So what we do on this gentleman is actually a couple of periapical PCOs. We leave his fused apex alone. We don't take it apart with the 3-column osteotomies. We interbodies at the bottom, and we actually use a kickstand construct to realign him in the coronal plane. So you see here is alignment is maintained in the sagittal plane and improved in the coronal plane following this reconstruction without doing 3-column osteotomy. Another patient here with a 57-degree thoracic, 79-degree lumbar, and 34-degree lumbosacral fractional curve. Again, the supine images, so a structural thoracic and structural lumbosacral curve. So here's the classification on this patient who has an aligned coronal and sagittal plane, but has marked regional alignment, especially in the sagittal plane also with thoracic lordosis and thoracolumbar kyphosis that we'd like to correct, as well as the regional coronal curves as well. So here we do a T3 to sacrum and a unilateral convex lumbar L1 PSO. So we only take out the convex portion of the L1 body and convex pedicle. We leave the concave pedicle as a hinge, and we compress and cantilever that L1 body to medialize it and ventralize it. You see the correction that's afforded on the coronal and sagittal plane films. And we also produce thoracic kyphosis via posterior osteotomies and reduction screws as well in the sagittal plane. With the result of very nice realignment in both coronal and sagittal planes. And the last case I'll highlight just again shows the individual nature of ADIS. So here's a 4S aligned patient, very large curves, but again, aligned in the coronal and sagittal plane, 69 years old. Her only complaint pretty much is stenosis, neurogenic claudication from the severe L3-4 stenosis, where she has rotatory subluxation at. So it doesn't matter what her classification is. All I do on her is a single level decompression and infusion on her. We don't treat her curves, we treat her symptoms. And here she is 2 years post-op with complete relief of her symptomatology. So again, highlighting that we're treating the patient, not the x-rays. We always have to keep that in mind. So thank you for allowing me to present this new radiographic classification system of ADIS, modeled after the well-accepted and long-standing AIS system. 3 components include the curve type, lumbosacral modifier, and global balance modifier, showing excellent interrelated reliability and posterior treatment options. Again, but plan to obviously add a lumbar MRI module soon for further direction on the lumbar and lumbosacral fractional curve treatments. And again, as I emphasized in the last case shown, ultimate ADIS surgical treatment needs to be individualized for each particular patient. And I thank you for your attention.
Thank you, Dr. Lenke. We've got about 5 minutes for questions, so if people want to put in the chat box or any of the panelists want to chime in, but I guess I'll ask the first question, and this is from the perspective of a deformity voyeur, for lack of a better term. We see a lot of our deformity cases. I don't do it in our conferences at TBI, and I found two things really interesting. Number one is, and perhaps you can answer the why part, is I've not seen reliance on supine x-rays. You know, our Scoli guys are all into the EOS and standing films and all these spinal pelvic parameters. And I think it's interesting, and I want to know kind of how you came up with using supine to determine, you know, which curves to fuse. And then the other part is specifically that. You seem on your cases to have less of those. Every patient gets spinal pelvic parameters, and we've got to make, you know, the PIL mismatch less and the SVA, and you mentioned it, but your approach seemed to be less reliant on that, where I've seen just from the outside in an increasing reliance on spinal pelvic and standing films.
Great, thanks, guys. Great questions. So I must give credit to Keith Bidwell, who basically early in my training, we started using supine images in the late 1980s in St. Louis at WashU on all our patients. So basically, even though we did get side benders because we thought we had to get side benders, and obviously for the AIS classification system, we use side benders because that was and still is the gold standard. Keith Bidwell and I have always gotten a single supine image on basically every deformity patient we've ever treated. And the rationale behind that, number one, is it's not subjective. It's not subjective. It's objective. You just lay the patient down, take gravity off the spine. You don't see maximum flexibility, but you see consistent flexibility, because no matter whether you lay that patient down in St. Louis, New York, or Tokyo, it's going to be the same decreased flexibility. And sometimes there's no change in flexibility because the patient's completely fused, right? And sometimes there's a fair degree of change in flexibility that you need to understand. But the nice thing also is that for alignment purposes, you see the patient kind of laying down like they are in the OR position, right? You know, we don't have patients doing benders in the OR, right? We're kind of, my mind goes from upright images to supine images to intraop images, which are all in the same plane, right? So that's how my brain works, and looking down that paradigm to then finally standing upright images. So it's pre-op to pre-op supine, pre-op upright, pre-op supine, intraop prone, post-op upright, all in the AP plane. So I think, again, I really, that's the way my brain works, because I've been using that now for over 30 years. And so I'm trying to really push this supine image as the universal flexibility film for all patients. EOS patients, I've got Michael Battalion out of Columbia using it, as well as EOS, little kids. AIS, I'm pushing that as well. We've got a publication on replacing the side benders for supine images on what criteria you use as structural curves in the AIS population. Now you see we're doing it for the ADIS population. So I really think if you, and all our fellows, a lot of our fellows use this. Once you obviously drink the Kool-Aid at WashU or Columbia from our fellowships, we're getting a group of surgeons using it. So I think if you start using it, you won't ever stop using it. It makes a lot of sense. Your second point, I'm not ignoring the lumbosacral and sacropelvic parameters, Scott. Those are all critically important. But for ADIS, I think they're not as critical. Most of these patients, and I showed a couple that were mildly malaligned in the sagittal plane, but most of these patients actually have fairly good regional sacropelvic alignment. That's not their biggest issue, right? They have more of their issue in the coronal plane. Which is, not what we're used to. Everything's been in the sagittal plane. The coronal plane has been the stepchild of the last 10 years, right, in adult deformity research. So the point being, we can't ignore the coronal plane. That's why I think this classification is timely. It really highlights more of the coronal plane that we can't ignore. Obviously, the sagittal plane is of critical importance, and then probably even more important than the coronal plane. I'm not saying that it isn't more important, but we have to pay a lot more attention to the coronal plane going forward as well.
Oh, thank you. One more comment. One of my other senior partners has coined the expression that spinal pelvic parameters are the discography of the 2020s.
Interesting. That's good. Interesting.
We have a question from Dr. Debosset.
Oh, please, Professor Debosset.
Yes,
good to see you.
Good morning. Good afternoon. I don't know where. In France, it's good night. But
good night.
Anyway,
exactly. Thank you for being here.
Anyway, I enjoy your talk, but I want to ask you, in some cases, do you use checking the sagittal plane flexibility? I mean, the same as the supine. You do the same for the sagittal plane. For example, to change the flexibility, BO test. I don't know why. You understand my
Yes,
my
of
question?
course. Yeah.
Yes.
The answer is an easy one. The answer is yes. Our patients all get sagittal plane supine images as well. The issue is, you probably know, it's sometimes very difficult from C7 to the sacrum to see the vertebrae and see the alignment quite well. So often we have to depend on the MRI, sagittal lumbar MRI or CT scan pre-op to truly assess the lumbar sagittal supine alignment, right? But the bottom line is, yes, it's very important, as you know, to assess that, because just like things change, taking gravity off the spine and the coronal plane, they can even change even more in the sagittal plane of those, segments that are not auto-fused or iatrogenically fused. So it's very critical to assess that and pre-op as well. So the answer is, we do assess that. Again, for this system, we did not include it in the classification because, again, most of the time, these patients are not horribly sagittally malaligned, although I did show, several cases that needed some a global realignment. But for the majority of ADIS patients, unless they're very old, it's more of a coronal plane issue than a sagittal plane issue.
My question was also for the upper part of the spine, for the cervicothoracic junction.
Right. Yes. So again, the answer is yes. We do get supine total body images to assess that. Again, because of shoulder interposition, sometimes it's hard, as you know, to see that area. So again, all my patients get a total spine MRI. So actually, I sometimes measure those segments on the MRI, because it's that, you can see the vertebrae better on the MRI, and also they've been laying there for a longer time in the MRI unit, so you get a true representation of how the cervical thoracic and proximal thoracic region relaxes over time. So the answer is yes. It's very important to assess all regions of the spine when you have gravity off it, because, as you know, it can change quite a bit, and it may impact your fusion levels and your correction techniques as well.
In the direction to prevent the PGK, especially.
Of course. Very good. Thank you, sir. You're welcome.
Thank you very much.
A couple more quick questions. One is, in all the cases you presented, what size rod do you use, and is it titanium or cobalt chrome? My
main correcting rod, which usually would go from top to bottom on at least one side, is 6.0 cobalt chrome. The contralateral side is invariably a 5.5/6.0 hybrid cobalt chrome, where I put 5.5 on top. And in a smaller patient with osteoporosis, I'll use 2 5.5 rods on top. I'll have transition rods on both top. But for the lumbar lumbosacral region, I always have 6.0 cobalt chrome rods. As you see, I'm often using 4 rods now at the bottom, as I showed on many of my constructs. So 4-3-2 transitioning with 2 rods at top, either 6.0 5.5 or 2 5.5s based on the amount of bone stock up top.
Another quick one: side bending or supine traction X-ray for more accurate determination of flexibility in adolescent spinal deformity.
Yeah. Again, I just still get supine images. If I have to see maximum correctability, I think traction X-rays are better for that. But typically, I will just compare the percent change from the upright curve to the supine curve. And that gives me a percent change. And because I'm doing this for 30 years, looking at that change, I can kind of tell how rigid that region of the spine is going to be by the percent change. If you need to prove to yourself how much you can correct it by pulling on it or whatever, getting side benders, that's fine. But honestly, if you get supine images and carefully look at all your patients consecutively over time, you'll get a good feel for how rigid those apices are based on the difference from the upright to supine. And you won't need any other images, honestly, Scott. That's what I've seen over time, as long as you get used to looking at those 2 images.
Great. And let's let Vince take us out with the last question.
Hi, Vince. How you doing?
Hey, hi, Larry. Great talk. I enjoy very much your talk. Seeing all your cases, it's my impression. Have you decreased the amount of 3 column osteotomies in this population compared to what you used to do 10, 15 years ago?
Absolutely. And all my ASD patients, I have in my 3-column osteotomy talk, I'm basically doing about 30 to 40% the PSOs, especially in adults that I used to 15 years ago, about 30 to 40% only. And that's because, again, much more aggressive use of posterior osteotomies, interbodies, positioning, realizing that you can just get more if you kind of work the spine, get good screw fixation, position the patient appropriately, do aggressive interbodies. I do them from the back, but you can do them from the front or from the side. It doesn't matter. But, people who do things from the front or side know that as well, right? You work the disc, you can get a lot of correction from that. So I just work the disc from the back, right? I do the same thing, just from the back. So absolutely much less 3-column osteotomies and logically less complications. 3-column osteotomies, I only do if I absolutely have to do them.